Hi, and welcome to 360RN. My name is Dr. Meredith Watkins, and today we're going to be talking about acute kidney injury. Now, this video is best supported through our Study Buddy workbook, so make sure you grab one for yourself. The link is in the description box below. Today's video, these are the things we're going to accomplish. We're going to talk about the pathophysiology, what's going wrong in the body during an acute kidney injury. We'll describe the three types of kidney injuries, the definition, the causes, as well as the solutions. We'll talk about the 4 phases of acute kidney injury and how we manage each of those phases. And then finally, we'll talk about risk factors, complications, teaching points, and how we evaluate whether a patient is getting better or getting worse. Acute kidney injury can be related to the nursing concepts of fluid and electrolytes, as well as urinary elimination. Now, these concepts are big tools for our toolbox that help inform us on a variety of different diseases. So if you haven't already, make sure that you watch these videos on fluid and electrolytes and urinary elimination, as they'll provide you a foundation that you need to understand this topic. This topic is also related to a body system, specifically the urinary system. So the more you understand how the body works the way it's supposed to, the more you'll be able to understand the dysfunction and then the interventions that we do to manage those dysfunctions. So let's start with pathophysiology. What is going wrong in the body during an acute kidney injury? Acute kidney injury, also known as AKI, is a sudden decrease in renal function. So the kidneys stop functioning the way they're meant to. So in order to understand exactly what's going on, we have to remember the specific renal functions of the kidneys. Now, this is described in more detail in the urinary elimination concept video. Link will be in the description for that as well. So if you're unfamiliar with that, pause here and go take a look at that video before jumping in. But as a reminder, the kidneys have 3 essential functions. The first is that they filter out waste. So think about it as trash in a trash can going out to the garbage dump, or a coffee filter filtering out the coffee particles. The first job and most important job of the kidneys is to filter out waste. The second job of the kidneys is to balance fluids. Our kidneys help decide how much of our body fluids we should keep because we need them, and how much of our body fluids we should excrete so that we have an appropriate balance of fluids in the body. Speaking of balance, the third and final main role of the kidneys is to balance electrolytes. And again, this is done through the loop of Henle and the body deciding how much of all of these different electrolytes, like potassium and sodium, should be maintained in the body and how much should be excreted. Remember, the body is always about homeostasis, finding balance in the amount of nutrients and fluids and electrolytes that our body has to maintain normal function, to maintain fluid volume, as well as maintaining our blood pressure. So when our kidneys have a day off and they call in sick, these are the functions that we're going to see a problem with: filtering out waste, balancing fluids, and managing electrolytes. Now, acute kidney injury, or AKI, used to be called acute renal failure. And that was a bit of a misnomer, a bit of a wrong name for this, because acute kidney injury is most of the time reversible. The good news is most of the time the kidneys can heal, and as long as we address the cause and find a solution, the kidneys will start to function again. So we switched this from acute renal failure to acute kidney injury. And remember, it's reversible about 80 to 90% of the time. Now, there are 3 types of acute kidney injury, and they're all based on where the problem started. So they can be pre-renal, intrarenal, or post-renal causes of acute kidney injury. Pre-renal means that it's a problem with the blood flow going into the kidneys. You see, blood flow goes through our kidneys so it can be filtered out, but the kidneys are an organ, and so the kidney itself needs blood flow and oxygenation to function. So if there's not enough blood flow going into the kidneys will not be able to do their job. Intrarenal means there's something wrong inside the filtration system of the kidney itself. And then post-renal means that the problem that caused the injury is somewhere after the kidneys, so in the ureters or the urethra or the bladder. The problem is after the kidneys in the urinary tract. So for each of these three types, pre-renal, intrarenal, and post-renal, we're going to talk about the definition, we're going to talk about causes, as well as solutions. So let's start with pre-renal acute kidney injury. The definition is that acute kidney injury from pre-renal causes is a lack of perfusion to the kidneys. So the kidneys are starved for oxygen and then therefore unable to do their job, unable to function because they're lacking the blood flow that they need to stay oxygenated and function. Now, this lack of perfusion, lack of blood flow to the kidneys has two main causes. Either there's not enough pump to move blood, the heart is tired and it's not pumping enough blood to get good blood flow to the kidneys themselves. And this can be things from like heart failure to a myocardial infarction, or it could be that there's just not enough blood at all. And this can be things like dehydration, internal bleeding, hypovolemia, or burns that cause massive fluid shifts. So either the kidneys are not getting enough blood flow because the pump isn't strong enough to get it there, the heart, or there's just not enough blood flow to pump around. Now, pre-renal acute kidney injury, the solutions are always going to be based on finding the root cause and fixing that. And so if the causes were not enough pump and not enough blood, the solutions are going to be related to those. Either improve pump function or increase blood volume. So things like cardiac meds, cardiac interventions, and increasing blood volume through things like IV fluids and blood products. Now, intrarenal acute kidney injury is damage to the kidney itself. It has enough blood flow going in and there's nothing wrong after the kidney. The problem is in the kidney. And so because of this, the kidney is unable to do their job. Causes for intrarenal acute kidney injury include three things: kidney killers, also known as nephrotoxic drugs, medications that cause damage to the kidneys. This is things like antibiotics, specifically vancomycin, and a drug class called aminoglycosides, NSAIDs, CT contrast dye, and ACE inhibitors, which is used for blood pressure. The second cause is infection. The most common of this is glomerulonephritis, an infection of the kidney itself. And finally, physical trauma, injury such as motor vehicle accidents and falls that cause the kidney to be injured directly. And finally, we have post-renal AKI. Post-renal AKI is the least common type of the three. It's defined as an obstruction after the kidneys that cause an increased pressure in the kidneys themselves. And then this increased pressure causes dysfunction of the kidneys. So if you think about a drain and water has to drain out, if there's a clog in that drain, water cannot drain out and it starts backing back up into the sink or into the toilet. And that's what's going on. There's some kind of obstruction after the kidneys before the urine leaves the body. And so urine can't flow out, so it flows back up. And when this urine flows back up into the kidneys, it causes a lot of pressure. And none of us can work under severe pressure, can we? The kidneys are no exception. So we have to figure out the reason for this obstruction, eliminate the obstruction so that urine can flow freely out of the kidneys and out through the urethral os. There are four main causes for this, and they all have to do with obstruction of the flow of urine. The first would be tumors, a tumor somewhere in the bladder, the urethra, or the ureters. The second would be benign prostatic hyperplasia, also known as BPH. Now, this is only in males, and the prostate is a small gland that sits right under the bladder. And if it becomes enlarged, it can actually squeeze off the urethra so that urine is not able to pass through. And if urine's not passing down, it's going to go back up. The third cause is neurogenic bladder, things like spinal cord injuries and neurologic diseases, where the brain is no longer triggered with the need to void or is unable to void. And patients with spinal cord injuries and neurologic diseases like this have to straight cath every 4 to 6 hours to empty their bladder. But if for some reason they do not do that, then urine would not be eliminated, and so the urine would back up and go back up into the kidneys. And finally, kidney stones. Kidney stones can happen anywhere from inside the renal pelvis itself, through the ureters, into the bladder, and out through the urethra. And if these stones are large enough, they can actually impede the flow of urine, causing an obstruction. Now, the solutions for post-renal acute kidney injury include removing the obstruction itself, so removing the kidney stone, having a TURP for an enlarged prostate, removing a tumor, or catheterizing on a schedule for a neurogenic bladder, ensuring that that bladder is emptied regularly so that it does not fill up. In addition to the 3 types of acute kidney injuries, there are 4 stages of acute kidney injuries. Make sure you write these down and let's talk about it. The first stage is initiation. The second is oligoanuria, meaning little to no urine. The third is polyuria. It's the opposite. There's way too much urine. And then finally is the recovery. For each of these stages, we're going to talk about the definition, the time period, signs and symptoms, diagnostics and labs, and finally interventions. So for stage 1, which is the initiation, the kidney is still feeling like a superhero. It's feeling pretty good, and this is from the start of the injury until symptoms appear. This is when people don't know they have a problem yet, and this can last from a few hours to a few days. And the goal here is prevention, recognizing the risk factors for AKI, recognizing the causes, and intervening so that we never get into AKI. Stage 2 is that oligoanuria. Oligo means a little bit of urine, and urine means making no urine. So this phase is associated with decreased urine output. The duration of this stage is usually 1 to 2 weeks, although some patients may skip this stage altogether. Now, when you're not making enough urine, you're not excreting any electrolytes, you're not excreting waste products, and you're not excreting fluid. And so you're at risk for things like cardiac rhythm abnormalities due to electrolyte imbalances, fluid volume overload, respiratory issues because of the fluid volume overload, and acid-base balance issues. Signs and symptoms of oligoanuria, stage 2, include fatigue and weakness, decreased urine output, altered mental status, and so remember that safety is a priority if there's an acute AMS change, itchy skin from the buildup of byproducts and waste products in the body, fluid volume overload, which is associated with things like swelling, crackles in the lungs, bounding pulses, and weight gain, and respiratory changes, either crackles in the lungs from fluid volume overload or even some Kussmaul's respirations due to metabolic acidosis. Diagnostics and labs are going to be looking at things like abnormal kidney labs and electrolyte imbalances. Specifically, the BUN and creatinine are going to increase. The GFR is going to decrease because the GFR tells us the filtration rate. And so if our kidneys are not doing a good job of filtering, the GFR will go down. We'll also see a decrease in urine output to approximately 50 to 500 mLs per day. And the specific gravity of any voided urine will be very concentrated, greater than 1.030. We will also note electrolyte imbalances, most notably a high potassium hyperkalemia. And hyperkalemia is going to be associated with EKG changes like peaked T waves, widening QRS, a prolonged PR interval. And we're going to see a low sodium, and this is called a dilutional hyponatremia. So there's so much fluid in the body that the amount of sodium is sort of diluted in all of that fluid, and so it appears that the sodium is lower. Anytime we see low sodium, we can see associated altered mental status as well. And finally, things like phosphorus will go up while calcium will go down, because remember, phosphorus and calcium are always inversely related as electrolytes. Additionally, we're going to see metabolic acidosis on the ABG. pH will be less than 7.35. And again, because of the hyperkalemia, we can see EKG changes, specifically peaked T waves, widening QRSs, and prolonged PR intervals. As a reminder, here is what a normal EKG looks like. So you've got your normal P wave, your QRS, and a nice T wave. But in hyperkalemia, you'll notice that the T wave is very peaked after those QRSs. It's much higher than the QRS itself. And this is a sign that the patient has too much potassium and would need to be checked for that. Remember, anytime you have a patient with electrolyte imbalance risks, they need to be on a cardiac monitor. So our goals for stage 2 is to manage these complications and take over for the kidneys. Specifically, most patients with acute kidney injury, if they're making very low to no urine, are going to be placed on hemodialysis. Hemodialysis is essentially an external kidney that takes over for the patient. So the patient would have emergency dialysis access placed, and then they would start on inpatient renal dialysis 3 days a week for a few hours each time. And during this process, the patient's blood is filtered out of the tube in their body into this machine. All of the waste products and excess fluid are filtered out in the machine, and then the filtered blood is put back into the patient. Interventions for stage 2 include strict INO, cardiac monitoring, daily weights, K-oxalate if the potassium is high. Sodium bicarb is a good solution for metabolic acidosis. Diuretics to encourage the kidneys to give out a little more urine, and dialysis to filter out waste products, excess fluid, and excess electrolytes. Now, stage 3 is when the kidneys start to recover. And at first, the kidneys are really good at filtering out fluid, but they're unable to concentrate the urine. And so stage 3, we see polyuria. Poly means lots, urea means urine. So we see extreme diuresis. We're talking 3 to 6 liters each day. So the kidneys are starting to excrete waste, that's great, but they cannot concentrate the urine. The duration of the stage usually lasts for 2 to 3 weeks, and the patients are at risk for things like dehydration and electrolyte imbalances. Signs and symptoms, we'll know the kidneys are starting to work again because we're going to see lots of urine, 3 to 6 liters a day. Their altered mental status will start improving, but we might start seeing, instead of a fluid volume overload, we might start noticing a fluid volume deficit because they're getting dehydrated from voiding out so much fluid. And so fluid volume deficit would be noted by things like dry mucous membranes and low blood pressure. Diagnostics for stage 3 include improving kidney labs. We would see BUN and creatinine improving GFR, and increased urine output. We also might see hypokalemia because the patient is now voiding out too much potassium. And the urine-specific gravity would be very, very dilute. The goals in stage 3 is to manage these complications and assist with recovery. These interventions include fluid replacement, which might sound crazy. We've just been doing fluid restriction and strict INOs, and now this patient might even need IV fluids to replace all the fluid that they're losing. Electrolyte replacement, strict INO, daily weights, and cardiac monitoring. And finally, stage 4, restitution, also known as recovery. This is when the kidneys return to normal, so the urine output, the GFR, BUN and creatinine, fluid and electrolytes all start to normalize. Now, the time period will vary. The initial improvement we'll start to see 1 to 2 weeks. Full recovery, however, can take up to 12 months. And unfortunately, 10 to 20% of patients with AKI will not experience recovery and will go into end-stage renal disease. Now, risk factors for acute kidney injury include an older age due to the kidneys being more tired and more susceptible to injury, a history of kidney problems, comorbidities like diabetes and heart failure, because those can cause perfusion issues, which could impact the kidneys. Severe dehydration, urinary blockages like BPH or kidney stones, sepsis, also a perfusion issue, and those nephrotoxic drugs, those kidney killers like NSAIDs, ACE inhibitors, diuretics, and antibiotics like vancomycin and aminoglycosides. So if your patients have any of these issues going on, recognize that they're at higher risk for AKI and make sure you're monitoring. So complications of acute kidney injury include fluid volume overload, and the patient may experience chest pain or shortness of breath. Electrolyte imbalances, which can result in cardiac arrhythmias and muscle weakness. It can result in permanent kidney damage for 10 to 20% of patients. And if left untreated, it could result in death from the rising amount of electrolyte imbalances and metabolic acidosis. So it is important as healthcare providers, as nurses, that we intervene early, recognize these symptoms, and get the patients the treatment that they need. Now, with anything that we do in nursing, we always want to recognize teaching as an important skill, an important part of including the patient in the plan of care. So we're going to want to teach our patients about the disease process itself. We want to have the patient avoid salt, potassium, and high phosphorus foods. They're going to be on a fluid limitation set by their provider. We want to teach them about dialysis and what to expect and why it's done. And then to teach all of our patients to use caution with nephrotoxic drugs. And finally, we want to talk about evaluating care. So if you have a patient with acute kidney injury, how do you know if they're improving or if they're getting worse? Let's talk about improving first. So signs of healthy kidneys that are improving would show a normal urine output, a normal specific gravity of their urine. Their BUN and creatinine and GFR would all be within normal limits. Their fluid and electrolytes would be well balanced, and their ABG would be within normal limits. Now, a kidney who's not doing well and not doing what we're expecting include things like oliguria and anuria, so little to no urine. The urine-specific gravity remains abnormal. There's an increase in BUN and creatinine. They have a fluid volume excess, showing that their kidneys are not releasing enough fluids, things like elevated blood pressure and edema, shortness of breath. Their electrolyte abnormalities would be present, things like elevated potassium and phosphorus. And finally, they would have a metabolic acidosis. So these are the signs you're looking for when things are not headed in the right direction. By having an understanding of acute kidney injury, the stages, the phases, the risk factors, and how we can intervene as nurses, we can give our patients the best chance of getting through this injury and getting back to having a normal functioning kidneys. That's going to wrap it up for today. Thanks so much for listening. And as always, you are smart, you are capable, you are loved, and you got this. I'll see you next time.